another rhythm for y'all to listen. I'm never quitting on my mission. I'ma roll with what I'm giving. Got some ambition, this new edition, filling positions. Looking at the void in myself and feeling what's missing. Better watch the way you going, better go in the right direction. In the moment you stressing, but you gon' be counting blessings. And I know that for certain. Keep on working, open curtains, haters swerving, cause they ain't ready for your final version. Whoa. I'm never gonna give up, fall down, I just gotta get up, yeah. Cause this is my road.
You're listening to the Tom Ficklin Show on WNHH LP 103.5 FM, your home for community radio.
Good morning, everyone. I am Holly Hackett. I am honored and thrilled to be hosting for Tom today. It's always been my honor, again, like I said, to host for Tom. And today we will be discussing direct contracting entities. I am joined today by some very wonderful and knowledgeable people who I am proud to be working alongside. And please excuse me if you can't understand me or if I have to duck in and out. I actually have COVID right now. I'm at the tail end, so please forgive me for having to maybe cough a few times. My apologies. So instead of me introducing everyone, I am going to go around the room and have everyone introduce themselves. I will start with Rana. Rana, please introduce yourself to everyone.
Thank you, Holly. Thank you for inviting me. I'm Rana Stuller. I live in New London. I am not a medical professional, unlike most of the guests here. I am an elderly activist, Connecticut resident who is on Medicare and only learned about these direct contracting entities about a month ago, and I'm really concerned. So thank you.
Thanks, Rana. I should also say that I too am not a medical professional, but I am a disabled person on Medicare. And I also found out about DCs about a month ago, and I am freaking out. So now to my right, your left, is Justin Halloran. Justin H., will you please introduce yourself?
Yeah, thank you so much for having me. My name is Justin Halloran. I'm a fourth-year medical student at Yale. I'm currently applying into psychiatry. I'm planning on going into child psychiatry. Similarly, discovered about DCEs pretty recently, but concerned like everyone else about how it's going to affect future practice for doctors and also how patients will receive care.
And directly underneath me is Justin P., as we call them, Justin H. and Justin P. in PNHP, Connecticut. So Justin Paglino, would you please share a little bit about yourself with us?
Sure. Holly, it's good to see you. I'm glad to know you're on the tail end of COVID. I didn't know you were ill, but it's good to see you're getting better. Yeah, my name's Justin Paglino. I live in Guilford. I have an MD and a PhD, and I was in pathology and basic science research in virology for many years, 15, 17 years or so. I now am retired from that area, but I still maintain an interest in healthcare and the quality of healthcare that we have in this country and the problems we have and the fact that we're the only country, the only wealthy country that doesn't guarantee healthcare for all its citizens, which is why I ran for Congress in the 3rd Congressional District in 2020, and I'm doing so again this year so that there's a candidate on the ballot who offers people the chance to express their support for single-payer healthcare at the ballot box, which is where I think is the most effective place to express your opinion. And although other places are also important. But direct contracting entities are a kind of a sleeper threat to Medicare as it exists. I mean, we already knew this year that we were going to have, not be getting a public option and so on. But it's really shocking to find out that there's this process going on that's privatizing Medicare without any recent act of Congress. We'll get into how all this came to be, but yeah, that's me. I'm Justin. I live in Guilford.
Thanks, Justin. Justin P. And Dr. Marilyn Vache is next. So, Marilyn, please introduce yourself.
Hi, Holly, and thank you for inviting me and a number of us from Physicians for a National Health Program, Connecticut chapter. We all, as Justin just expressed, really support single-payer healthcare, but there is a very strong counter movement in this country to privatize healthcare. And this program that we're here to talk about is one that really flew under the radar for many of us. There are patients now enrolled in this program that didn't even know they were being enrolled in this program, which is really outrageous. So that's why I'm here. I'm a psychiatrist and I live in New London.
Thank you, Marilyn. And joining us for the first time on this program is Chuck Panaccio, which, Chuck, I have to tell you, because of you and One Payer States, that's the reason we found out about this horrible thing happening. So I thank you so much. And I thank you for joining us. So please tell everyone who doesn't know who you are a little bit more about you. Thank you.
Oh, absolutely, Holly, and I'm pulling for your health. I got the COVID breakthrough last year or earlier this, late last year, Delta. But just a little bit of background. So I'm president of One Payer States. We were founded back in 2009. A consortium of about 22 states that are working at adopting universal healthcare systems at the state level, similar to the way Canada got to national health care by adopting it in the province of Saskatchewan. So we support our sisters and brothers at all levels, local, state, and national, wherever the opportunities are. And we're about helping educate ourselves, create solidarity, support, coalition building. And frankly, I think it all starts with this notion of justice for all. We have to connect all of our justice campaigns here, of course, with healthcare justice, but we have to talk about the social determinants of health as directly connected to healthcare outcomes. And that way we'll be able to create the capacity to win on each of these issues. And that's really the premise. And I'm here really out of solidarity to continue learning and to support everyone. And I'm deeply grateful. There's a lot to do. It's 2022. We have a lot to do. My background, I used to live in Norwalk, Connecticut as a kid, actually. I was going through some old clippings of the New York Mets, 1969. That was the big hoop back in the day when I was living in Norwalk. And I have a PhD in history. So I actually went back to school to solidify my own better understanding of my activism, which dates back to age 13. So in any case, I'm really grateful for folks here. And I was on the phone with Susan Rogers last week. You know, she got COVID. I don't know if folks know that, the president of PNHP. But she's doing much better today. So just all the best wishes from the One Payer States community to our great friends here in Connecticut. Thank you ever so much.
Thank you so much, Chuck. I see a few others have joined us. Mike Goodman, would you like to introduce yourself?
Yeah, sure. My name is Mike Goodman. I live in Wisconsin. I've been following OPS and some of the Zoom calls from time to time when I'm around and learn of them with enough notice. And I think what you're doing is great. And obviously, I'm a firm advocate of single payer. And I've had the advantage, so to speak, of working in the insurance industry. So I know firsthand just how ugly things are there. And I'm pretty sure that if they treat their employees the way I was treated, they treat their policyholders even worse. Thanks.
Thank you for being here, Mike. And I see that Hank from Maine All Care is here as well. Would you like to introduce yourself?
Sure. Hi. I just got off work, so the camera's not on. But anyway, so I'm Maine All Care is a C3 a chapter of a PNHP, and we've been working on state-based plans, just like everybody else, as well as the federal. and I'm a working stiff in an emergency department, and so don't get COVID. And I've missed the other onlines for DCE, so I'm going to listen and learn. Thank you.
Thank you. Okay, so well, it's too late for some of us because some of us did already get COVID, but thank you. Now, from what I understand, these DCEs are just detrimental to basically Medicare, period. It will change, it will no longer be a public Medicare. It will just be a privatized system run by the for-profit insurance companies, from what I've read. And you know, again, not, just being a layperson and just finding out about this just about a month ago and just learning, I'm sure that there's a lot more information, and I'd like to just open it up for discussion, not to talk over each other, but just to kind of discuss what everyone's thoughts are. And I was really upset to find out, like Chuck had said, people are already being switched into these DCEs without their knowledge. And there's nothing they can do about this. Once you're in this DCE, you can't be taken out of it. Even if you call to be switched out, you cannot be taken out of it. And that's what people in one of the counties of Washington State were being told, at least. There's nothing you can do. That's it. You're done. So we need to stop this. But so can someone give me the easiest, most simple definition of what a DCE is, please?
I could take a stab at it. So my understanding is a DCE is an entity that is for profit that wants to make money. It could be lots of different kinds of, it could be an insurance company. In many cases it is. It could be an investment bank that is just looking to find a way to make money. And they found a way to make their way into making money from people who are enrolled in traditional Medicare. And the way that they do this is Medicare contracts with them and gives them a certain amount of money, and then kind of puts them in charge of the enrollees' medical care. So they're allowed to keep using whatever network, the network that they've been using, I think. But the direct contracting entity finds ways to put restrictions on their care so that they can make a profit. And in many cases, they think they're going to make a lot of profit. And they're allowed to keep as much as 40% of the money they get from Medicare as, expenses or profit. And meaning they only are required to spend 60% of that money that they get from Medicare on actual patient care. So if they get $100, the DCE gets $100 from Medicare, from the federal government. They spend $60 of it on your medical care, and then keep $40 as profit. That basically means, the cost of healthcare. We're now spending 40% of the money on just going into people's profits. So Wall Street sees this as a gold rush, a chance to make a huge amount of money. They're investing in this left and right. They're basically coming for the federal Medicare dollars. Now that they don't all have to be spent on patient care, they can go into private investors' pockets. This is, there's a requirement. It's a medical loss ratio for insurance companies and for Medicare, that a certain amount of percentage of the money that they spend has to go towards patient care. And that's they call it a medical loss ratio. And the requirements are so low on this and that's what makes it a profit-making opportunity. So it's very concerning because this doesn't in any way, I think, spell out better health care coming down the pike. This spells out more restrictions in healthcare. This means, because that's how they're going to make more profit. We're letting the profit motive come in, not just to Medicare Advantage where it already exists, but now to traditional Medicare. So there's about 60 million people in Medicare, and if I'm correct, and Medicare Advantage, I'm not sure, is maybe a quarter of those, but
45%.
45%.
Yeah.
So maybe 35 million, and then like 30 million who are or so on Medicare traditional, which is nonprofit healthcare, single payer, nonprofit healthcare that we support expanding and making universal and making free. But all these patients now are being involuntarily realigned or aligned in to have their care being their care is now being put into the hands of these DCEs without them having to consent. The physicians are the ones who get to make the choice, and maybe they get some kind of incentive to do so. But some of those profits maybe get thrown their way a little bit. But it's really, I think it's really hard to argue this is in the patient's best interest in any way. And I don't want to take up too much of the airtime, but unfortunately, this is something that was made possible by Obamacare, and probably with the best of intentions. But there was a clause in Obamacare, the Affordable Care Act, passed in 2010, that gave Medicare the authority to experiment with different cost-saving measures, and they created this Center for Innovation that has the authority to make changes like this without additional congressional actions.
I think that's part of the reason that we're here today, is to make sure that this doesn't happen without some kind of public input. Because what happened was there was such an uproar for the geo version, the geographical one, that everyone wrote to their Congress people and contacted CMMI, I believe it is, and Centers for Medicare and Medicaid Innovation, yes, CMMI. And so they put on hold that one geographical DCE program. But the other one, the GoPro, I think it is not on hold, and that is still being done. So that's why we're here today, is to let people know, A, what it is, B, that it is happening, and C, what we can do to try to stop it. So I just want to make sure that we're clear. This is happening. It is not something that's not happening. Go ahead, Marilyn. I'm sorry.
Well, I'd like to say it's not happening in Connecticut yet, so we still have some time. There are two entities, I love that word, which just means companies, really, that are contracted to provide services in Connecticut, but nobody signed up with them. No provider has signed up with them. The way we can make a difference is by being in touch with the Health and Human Services Department and trying to get more powerful people in touch with Health and Human Services Department. In other words, people like Delaro and Courtney, to be in touch with HHS, to be in touch with CMMI, and say, this is not the right thing. It's a waste of taxpayer dollars, and ultimately it's going to be more managed care. In other words, more pressure on doctors to limit services, more pressure on home health care nurses not to show up every day. I mean, every way you can save money, doctors, nurses, healthcare organizations are going to be pressured to save money. So we need to speak up, and now, because it'll be fully national by the end of this year, as I understand it.
I do want to kind of point out also that even if you look at their goals, it's sort of based on a fallacy. Even going to the CMS.gov website, they say, risk sharing options aimed at reducing expenditures while preserving patient care. And it's based on a fallacy that the reason that healthcare is expensive in this country is that people overuse it. And that isn't true. That isn't why healthcare is expensive. So all of these outsourcing of risk schemes end up costing more money than just providing the care that people need. And I'm in the Medicare Advantage plan, not by my choice, actually, because I'm in the state retiree group, which Kevin Lembo, whom in general I love, but he switched all the retirees to Advantage plans about 2 or 3 years ago. And it doesn't affect the care I get personally, but you can tell the difference. It's like we get advertising from United Healthcare every week. They say, take advantage of your gym membership, do this, do that. They're always telling us what they're doing for us. And yet when my husband broke his femur, had to have a hip replacement, and they paid it all, but before they paid it, they made sure that he hadn't fallen in a department store or an office building because they were going to sue wherever he fell. So you could see that even though they did cover it, they were trying to shift the expense to someone else before they did. And I think traditional Medicare would not have handled it that way.
And how many of your dollars went to their marketing and to their departments of insurance and their legal departments instead of your healthcare?
Indeed.
And I just want to throw in that, this myth that healthcare is expensive because people are overusing it is a myth. And one of the real reasons that healthcare is too expensive is because of making it a for-profit entity. And one of the things that the Advantage folks, providers, have figured out how to do to make a bigger profit is to inflate the coding of their patients. So if a patient has, asthma, they figured out, okay, how can we code this in a way that gets us the largest payment for this patient? Call it COPD stage 3 or whatever. There are a million tricks that they figured out because they get a certain amount of money based on the list of diagnoses a patient has. So if a patient has, A, B, and C, they're now digging up to see, well, what other diagnoses can we give them? Let's give them D and E and F. Let's bump up this diagnostic criteria. Anything they can get away with, because in the end, that's their bottom line of how much money they're getting. When they give you a list of diagnoses, that determines how much money they get from the federal government, from the taxpayer. And then, so they're motivated to get as much money as they can that way, and then spend as little as they can on actual care to make profit. And this has been going on with Medicare Advantage already, but now they're going to make their way into the half of people, or the 55% who are enrolled in traditional Medicare, and start making money on that side now in the same devious way.
Well, I actually have been a victim of such upcoding, to be honest, and I'm really pissed off about it. I can't even imagine how many other people there are. First of all, there is a huge issue around mental health. And when you're diagnosed with a mental health illness or issue, or a diagnosis, shall we say, you are 100% treated differently by the majority of physiological doctors. I don't care. Y'all could say no. It is true. In an emergency room situation, if a doctor sees that you have this mental illness or that mental illness, you are treated differently. Okay? So now when I get upcoded and I see that I have 3 different mental health diagnoses that I know I don't have, and I'm like, Well, no wonder they they had a guard outside my door. No wonder people were questioning if I was seriously ill or not. And no wonder they didn't want my mother in with me when I've had 6 brain surgeries, so I can't remember. But they were wondering if my mother was part of the problem. And I'm like, I'm looking through my chart and I'm like, what are these doing here? I had no idea that they were on my chart, and that should be illegal. You are, that is a part of your permanent medical record, and it should not be so. If you do not have a physiological issue, if you do not have a mental health diagnosis, it should not be in your permanent medical record, period. That should be illegal and a part of the Hippocratic oath that these insurance companies are breaking, and they are can do serious harm. Like, I don't have a few of the other issues, and thank God I figured it out and my doctors took it off my record. But other people don't know to look on their records to do this, and they're stuck in these molds because these insurance companies, excuse me, upcode them. And that's not right and it's not fair. And the stigma around mental health in and of itself is not fair. But it happens. And I know it happens because it happened to me and it happens to almost everyone in my coalition. So it happens and it has to stop. But still, if you don't have the diagnoses, it does not belong on your permanent medical record. And that is also something that we need to talk to our politicians about to change.
Thank you for sharing a real life story, Holly. I mean, there's so many ways this can go south. One of our members has pointed out something I wanted to get to, which is we do need to be talking to our legislators so that they can be talking to HHC, Health and Human Services, HHS. And for example, I am trying to have a conversation with, I've had emails with the healthcare policy aide for Representative Courtney, Maria Castegno, I believe is her name. So I think for all of us in different districts, we need to figure out who's the healthcare aide, policy aide for your representative, Deloro, Joanna Hannah Hayes, Blumenthal, everybody that, who represents us. We need to let their offices know that, yeah, there are eyes on this. And we know you guys can't change it. It's beyond your legislative purview, unfortunately, but you can be talking to the people that you fund, like HHS.
Yeah, and someone Rana pointed out in the chat that we have 2 representatives out of our 7 that support Medicare for all, single payer healthcare, and those are Senator Richard Blumenthal and Representative Johanna Hayes. And so they may be the most likely allies, but not necessarily the only allies in this specific fight, because this is really taking Medicare backwards. This is not even holding the status quo. This is moving backwards towards privatization of one of the most important federal programs we have, and it really is outrageous. And thank you, Holly, for hosting this event, because it really is important to raise the alarm bells on this issue.
And Chuck, you have your hand up. Please go ahead.
Yeah, I just wanted, if folks hadn't heard, I did have an extensive conversation. I mentioned to you, I think, Susan Rogers, the relatively new president of PNHP, led a delegation to Washington, D.C. and approached HHS. And they did finally get an audience with I guess you would say, a mid to upper level bureaucrat. They were trying to get to Javier Becerra, who's the secretary. And the response they got was that, oh, there's no harm here. This is simply an expansion of the ACOs And I think, and they just view it as sort of experimenting and giving the opportunity. They believe that it actually is going to lead to savings. They're delusional, but this is really the narrative that wraps around the folks at Health and Human Services. So we have to break through with our members of Congress. And I did put in the chat there, I think Katie Porter from California and Pramila Jayapal of Washington. I think they're the two primary point people coming from the Congressional Progressive Caucus. So to Marilyn's point, yeah, identifying your leg aides and then getting them hooked up with the legislative aides and those other key offices, and then just keep pushing the conversation upward. And then work with our partners on the outside, including PNHP, One Payer States, Healthcare Now, Labor for Single Payer, and all the state level organizations, National Nurses Union, of course, as well. We just have to keep pushing. So again, grateful for all you're doing, tremendous ideas. I guess the last thing I would just say for now is that I spend just a lot of time connecting the dots across institutions, and we've seen the same phenomenon in higher education, where I was fired for union organizing earlier this year. We see the same phenomenon in the media. We see the same phenomenon, of course, in the military, which arguably is where it all started, the military-industrial complex. But it's just to understand and not overwhelm ourselves, but to see that there's that what's happening here, this, and I call it profit first, not even for profit, it's profit first, is they bake their profit into their business model before they pay out for a single service. So it's baked in. So I call it profit first. And I think it may be a slight language shift, but I think it's important because it delegitimizes their business. When people hear for profit, they think, oh, well, of course, everybody needs to make a profit in the business world. But if you push the argument and say, no, this is about making money first before paying out anything. They call it medical loss ratio. I've learned this from Wendell Potter, but it's just a game. And it's all about, like Justin said, it's all about making money. And so that's just got to stop. Thank you.
Thank you, Chuck. And next hand is Hank. So please go ahead.
Great, thanks. So when the profit first idea is, I compare it to the subprime housing sort of is why did they go to the subprime market? Because they're just an extraction of fees. And the more loans they could get on the books, the more fees they could extract. At least that was the initial, note. So I'm looking for ways to how to explain this to and the talking points. And I was just wondering if you could discuss some of the talking points that has been presented. So I compare it, let's say, to the subprime housing market of, I'm just a hedge fund trying to sign up people to extract fees. Profit first. I don't really care whether people are going to pay off their loans or what the downstream effects are. I'm just here to sign up. I get a fee. I just want to build volume so I can extract more fees, and the downstream effects I don't care about because I'm going to pass it on to somebody else. So the eventual distortion of bedside healthcare that will come from this is the downstream effect that happens downstream. We've also wondered, again, how to use this as a learning point for us and as a learning point for legislatures. Everybody's been trying to wonder how to get under the hood of Medicare Advantage. What was that? And how come they're making so much money? And again, you may have been in the OPS, email trains, and if traditional Medicare is a 2% overhead and Medicare Advantage has a 15% overhead, okay, now we're starting to understand where the extraction of fees coming, where the profit first. Why would a hedge fund with gobs of money want to get into this business other than just to extract fees? So I think this is an example, looking for opportunities in sad situations and bad situations. Could we use this as a teaching point and as a way to get under the hood of Medicare Advantage? And that whole concept of why do these hedge fund companies want to get their hands on federal money? Why? Ronald Reagan said it was that poor welfare mom who wanted to get their hands on federal money. Why would hedge fund managers really, corporate folks want to get their hands on federal money? Oh, okay, so they can extract fees. Okay, so, yeah, so that question is how to use this as a teaching point, because I'm assuming that people will get upset. People will find that they've been enrolled in this without their choice. And as it'll probably roll out for a while, because I don't think that Biden is going to either. They don't understand it for all the reasons you've talked about, or they're too busy, or they don't care because of of campaign contributions, et cetera, all the different reasons they may not care and why this is probably going to happen. But here's a chance to use it as an opportunity to learn something ourselves, and also as a sore point with regular people as it starts and they start getting enrolling. So just my is I'm always wondering what kind of talking points are we going to use, and how can we learn from this and use it to our advantage? And many of the comments that Chuck laid out again, and yeah, okay. So those are the points. How to use it for a teaching point and for our advantage. Thanks.
Thank you. And Justin, you've been very patient. Please go ahead.
Thank you, Holly. Yeah, I wanted to circle back to a point that Chuck made, just about the savings that the Medicare Innovation Centers estimating that they'll be able to receive. And I think, if you're treating it in terms of federal dollars going into the system, it's possible that they might get some savings, but we have to be asking where are those savings going to come from? Either the services are cheaper or you're providing fewer services. And so if you're, going to be paying physicians more, which is how they're advertising to physicians to enroll in these programs, that's essentially the physicians group's sales pitch to physicians to sign up. Well, then where are the savings actually coming from? They're coming from denial of services, right? And that's, as Justin Biglino mentioned, and as others have mentioned, kind of part and participle of having a for-profit company that deals in health insurance. The idea is that you provide as few services as possible and take in as much funds as possible. So as Hank also mentioned, why would they want to get into these federal dollars? It's because there's a lot of money going towards it. 776 billion spent on Medicare last year. So a huge pool of funds that they could be drawing out from. And as was mentioned, the cap on how much they can use on overhead and profits, much higher than what we allow for Medicare Advantage. So pretty significant profit incentive there.
Yeah, and maybe they'll be able to save money, and they'll brag about it, right? Maybe Medicare will cheer that on, they'll say that's a victory. They'll say, look, Obamacare was passed to bring costs down, and we're bringing costs down. Hooray for us! But the question is, how are they bringing costs down? And especially if they're giving out more money as profits to these private entities, these DCEs, that's even less money to be spent on care. So they're not saving money just by spending less on. They're saving money at both ends. There's even less money for healthcare when there's a profit to be made. And they'll still brag about it like it's an accomplishment.
Yeah. And that's I'm going to interrupt you, Justin. I'm sorry, Justin H. To kind of address what Mike wrote in the chat. He said the incentive to minimize care is a solid point. My whole entire point for being here and for doing this show for Tom and hopefully for the New Haven area to understand is that I'm sick and tired of everyone crapping all over disabled, low income, and elderly people. Enough is enough. Other people who can afford things, I know it sucks for your care to be minimized, but it always seems to be on the backs of the elderly and disabled and poor people. And enough is enough with that. And I'm tired of it. And I'm really pissed and I'm really angry. And if pissed is a terrible word to use, my apologies, but not really, because I'm angry. And And I was once told by a politician, and I've said this before on this show, and I'm going to say it again, that the easiest thing politically to cut is services to the elderly and or disabled, because we do not have the lobbyists. Well, I'm still mad about that, and I will never stop being mad about that, because I'm going to keep going until change is made. And I'm going to keep yelling from the rooftops all of these crappy things that are happening to people like myself who are elderly, not elderly, but disabled and of low income, because not enough people have the people in my life that I have here, and to tell them that. So I want to make sure that everyone understands that these direct contracting entities are going to take over Medicare and give you less care, not give you more opportunities, not give you more choices like Medicare Advantage tries to tell you they do, because they don't. They just deny your care, give you less care, and that's all that they do. It's not anything greater, it's worse. So this is the whole reason I'm here. Your care will get worse, your health will get worse, and if you don't have health, you have nothing, as this whole COVID thing has taught us. So why we're not running in the other direction, these politicians have no idea, because we pay for their Cadillac of all Cadillac insurances, and they don't have to worry. So of course they don't have any idea what we're talking about, because they don't have to worry. I'm sorry. Justin Halloran, do you still have to talk about something? And then I'll talk to Marilyn.
Just a brief point about how these are sort of being sold to patients. If you look at some of the statements in favor of these programs, they advertise that they have a few benefits to patients. For example, they might provide a ride to your doctor's office. They might provide you with some reimbursement if you have to miss work. And these are programs that are not available to traditional Medicare beneficiaries. Also, for example, dental care, which was a proposal to be added to traditional Medicare that didn't go through. And so to my mind, what is essentially happening is that they're providing these small nickel and dime benefits for beneficiaries in these programs, especially to incentivize low-income people to enroll in these who might have fewer options for how to access care otherwise. And then the tail end of that is that they are denied care that they would otherwise be receiving. So I just think in terms of your point about economic justice, I think we should be thinking about why people are being put in these and why they might feel pressured to be put in these programs. Some of that is going to be
It's kind of like the gym membership that United Healthcare keeps trying to sell me.
Mm-hmm. Yeah, exactly. Yeah, so I just think we should be thinking about, who's actually going to be put in these, and is there an economic justice component to that?
Thanks, Justin. And Marilyn, I saw you had your hand up. You're on mute.
I think that's a really good point, Justin. There's a reason why these programs like Medicare Advantage are popular, because they do have very minimal copays. They offer dental, vision, and hearing, things that traditional Medicare doesn't, but that those of us who advocate for single-payer healthcare know really need to be in the new program that we want to see happen. I have written some talking points, and we can address those now or later, but I'm trying to summarize, like, what are the main things we need to know about this? What are the main things we need to have our listeners communicate to others about? So we can address those whenever you want to, Holly.
I think that's pretty important to do now, seeing how we only have 9 more minutes.
Okay. So the overview is the Department of HHS has a mission to spend healthcare dollars wisely and sponsors experiments to see what can be better. One experiment is direct contracting entities, and which is really just another form of managed care organization like Medicare Advantage. And it uses middlemen to control how healthcare providers do their jobs and what patients can get. Third, healthcare providers, private equity firms, venture capitalists, and insurance companies can own these. Most of those are pretty strongly profit-driven. Fourth, their goal is to make a profit, and they have lots of smart people to figure out how to get the maximum amount of money from taxpayers and how to restrict care. I should add in here, and by the way, as mentioned before, people can be enrolled without their knowledge or consent. And 5, Congress can't stop this. Only the administration can. So we have to pressure the administration directly and through our elected representatives.
Those are great, Marilyn. Thank you. Go ahead, Justin P. Sorry.
Oh, thank you. Yeah, I can't resist putting on my politician hat for a second. This is just so outrageous. This influence of money on our political system. Money talks, and it's coming in and it's influencing our government, and it's saying, this is the way we want you to do things, because if you do things this way, we have a business model that's going to be able to take advantage of this system and make profit for us and, you know, make us wealthy. And this is, we can all understand wanting money. That's an incentive, but for all of us. But this is our national health care. This is our common good. This is the public welfare. And if the people have to come out and speak and say to the government, make it clear what we want, and we want ourselves prioritized. And if money, either we the people are going to get listened to, or the money's going to get listened to. And it's so frustrating to see the money winning the day on this battle and winning the argument. And the only solution is for we the people to stand up and speak. And, you know, my perspective is politicians that take money from political action committees and are listening to money. They're not listening to people. And that's why I'm a member of the Green Party, which takes no corporate money. And, you know, my opponent, Representative DeLauro, she does take PAC money. She doesn't support single-payer healthcare, and I do, because I listen to the people, and that's my first priority. And so I'm sorry for, you know, injecting my political message into this, but I think it's really applicable. It's really important here that, you know, we have a system that's getting sold out. And it's like someone mentioned earlier, it's not just happening in healthcare, it's happening in energy, it's happening in education, it's happening in our prison system and our justice system. It's happening all over the place. People are finding a way to make money, and they spend money on politicians to get the system they need to make a profit. And it's up to us to reject that, and reject that when we vote, and reject that and tell our politicians we're not accepting that. We want a system that's set up for us, not for profit-making entities. And stop selling out our public services to these private interests. It's really maddening. It's really frustrating, and people really get hurt. And that's
in the
big
last
picture,
couple
in my
minutes,
opinion.
I think we should give people some websites where they can get. Sorry, Justin, but we got like a 3-minute thing where they can get more information about the issue and what to do about it.
Yes, thank you, Rana. And Chuck has put in the information about letters to representatives, senators, and HHS Secretary Xavier Becerra in the chat. I will send out to our comms team to put on our website, and at Medicare for the number 4 allct.org. And Marilyn, or Justin's, I went totally blank. Is it PNHP CT? Can you guys put in the chat the Facebook pages for PNHP Connecticut?
No problem.
Thank you, because I totally went blank. My apologies. So you guys can do that. You can go to One Payer States, and Chuck, please feel free to put in your information too in there, and anyone else who has, you know, their information. That's where I got most of mine, was PNHP and from One Payer States. So we're going to really try to take a serious look at this and make sure that while we're trying to do our state and local and federal legislative efforts, that we will also make sure to keep this in the backs of our minds too, because this is scary. This could just not only affect Medicare, but they could come on in and start affecting Medicaid as well. This is not just a one-off, guys. Once they can get their hands on federal monies, it could go all kinds of worse, and that's what's scaring me even more so. So that's, I just see this going in a much, much worse situation, it affecting not just Medicare, but affecting Medicaid. And even our really good in Connecticut, Husky is tremendously good coverage. And I don't want that to change for any of our people, but it will if this happens to go through. It's scary. It's scary that these for-profit entities, or wait, I'm supposed to use now. Chuck, help me. What's the word? What's the term? I wrote it down so I wouldn't forget.
Profit first.
Thank you. These profit first. Thank you, Marilyn. These profit first entities are taking over our healthcare industries. And we're supposed to have healthcare, not insurance. Healthcare, and healthcare is a human right. It should not be dictated to us from some executive sitting behind a desk on Wall Street. That is not what our healthcare should be about. So I want to thank everyone for joining me today. Rana, Justin Halloran, Justin Paglino, Marilyn Vache, Mike Goodman, Chuck Panaccio, thank you so much. Hank from Maine All Care, and Betty, I'm sorry I didn't acknowledge you. I apologize. So I want to thank everyone for being here and everyone for listening. And please look up DCEs and make sure you write those letters, you contact your legislators, and make sure that they put a stop to this, because it is very harmful and it's very scary. So thank you so much for listening, everyone. And Tom, I hope I did right by you. Thank you all so much. Take care.
This is Harry Droz, and you're listening to WNHHLP 103.5 FM New Haven.
With what I'm giving, got some ambition, this new edition, filling positions, looking at the void in myself and feeling what's missing. Better watch the way you going, better go in the right direction. In the moment you stressing, but you gonna be counting blessings, and I know that for certain. Keep on working, open curtains, haters swerving, cause they ain't ready for your final version. I'm never gonna give up, fall down, I just gotta get up, yeah. Cause this is my road, lights, camera, action, I'm ready to go. I'm never